So with a title like the Better Than Average Myth, and considering I'm going to be talking about dentist skills and their perception of those skills, I feel the need to start with a disclosure that I'm a very average dentist. You haven't seen a lot of average dentists or technicians up here for the last 2 days, but I promise you that I am one. As an example, I was interviewing one of my dental school instructors for a dental magazine. And I told him, I said, I often refer to myself as an average dentist. You spent 4 years with me in dental school. Do you think that's a fair assessment of my talents? And he said, no, Mike, I don't. And I said, phew. He said, those 4 years were definitely below average. And I said, ouch, really? All right, well, at least he's honest. And it's true, and today I know what was holding me back. It's these. Specifically this one, the left one, that was holding me back. The right one, once a week, I'll look at and I'll go, well done. I'm kind of impressed with something that it's done. It's the left one that has the dexterity of like a 1-month-old baby that's worrying, because the problem is I'm left-handed. Oh, thank you, God. Yeah, thank you for that little burden in life. And so my struggle or my path in dentistry has become to try to get above average results with a below average set of hands. And I know it might seem like it's false modesty on my part, that secretly I have tons of skill in my hands, like all the other speakers and technicians and dentists you've seen up here for the last 2 years. But I want to offer you a snippet from a live surgery that I did. The one that you guys did, by the way, was magnificent yesterday. Here's a live surgery that I was doing. This is several years back, pre-COVID. This is still when you could get saliva and aerosol over your watch and then take it home and get it all over your arms. Now we have full-length stuff on. So I'm holding these stone models in my hand. I'm going to move the models from here to here, and we're going to compare the recontouring on the model that my technician has done to the preparation that I've done in the teeth. So I'm simply going to take the models and move them over here. And that's when that happens. And just like you guys, we had 2 cameras filming it too. So, oh God, you got to see it from another angle as well. And okay, this part never happened. This is just the video crew making fun of me. That defies the laws of gravity. That never actually happened. So look at this. This is my good hand, my right hand, the one I just got done bragging about. I have a rubber latex glove on. That should increase my grip strength on the models. And all I'm doing is moving them from here to here. I'm not going behind the back. I'm not going to juggle. I'm not doing anything fancy. And as I move the models over, they slip out of my hand. They reach terminal velocity very quickly. They slam into the patient's forehead, who happened to be a dental technician. Her forehead, her frontal sinus compresses and then rebounds, no fracture, thankfully, but the models fall on the floor. And this is a live surgery, so you have to make a decision very quickly. And my decision is, this never happened. I'm going to pretend this never happened. I'm going to hope everybody in the audience did a long blink for some reason or lost consciousness. This is before everybody was on their cell phones during the lecture. So I was just kind of hoping against hope. But when I looked down, I noticed you could see powder from the model on the patient's forehead. It's like if you watch police crime shows when they find the body and they put the chalk outline around it. I looked at her forehead and I saw a crime scene because I could see the chalk outline of where the model's hit. So I immediately go in, if you notice, and I go in and I sweep it away. This is a felony in America, by the way, disturbing a crime scene, and I was willing to go to jail because of this live surgery. So I swept it away and I ended up sweeping the pieces of plaster into her hair, which is how I got caught at the end of the surgery when she saw it. Because as she was leaving, she said, Dr. DiTolla, what happened halfway during the procedure? I said, I don't know, where we put the retraction cord in? She goes, no, that wasn't it. I said, when we put that impression in your mouth, you bit down on it? She said, no, that wasn't it. She said, it seemed like halfway during the appointment, 2 large rocks hit me in the head. I was like, what? You think we're doing dentistry on a construction site? That didn't happen. So I just pretend it doesn't happen. So watch, I drop the models, boom, I destroy the crime scene, and then I'm right back to the teeth, all business. Because it's my assistant who's the one who starts patting her head because it starts swelling. She starts to get a hematoma. And so all I'm saying is, I know your live surgery went a little long yesterday, but just be glad that the patient didn't have to enter the concussion protocol like mine did at the end of that surgery. So consider yours successful. So the better than average myth, one of the easiest ways to think about this, because this is something that applies to everybody regardless of your profession. There's been multiple studies in the US where 85 to 88% of drivers have identified themselves as having better than average driving skills. Now, I'm not a mathematician, but obviously math does not allow 85 to 88% people to be above average when it comes to driving. And I don't know if it's like that in Germany too. I know you guys have a much more rigorous driving test. I know you have an authority that makes sure that your car's up to date and it's safe. We do not have that in Southern California. There's piece of crap cars breaking down on the sides of the freeways all the time. I admire when I look around and see in Germany what you guys do in terms of driving. The reason this better than average myth takes place is because what's known as the Dunningkruger effect. And these are two clinical psychologists from Cornell University who started investigating this 30 years ago and really were able to quantify what's happening here. And it's a cognitive bias where people with low to average abilities overestimate their abilities. There's over now 100 plus studies confirming the effect. Unfortunately, the people with the least ability are the most likely to overestimate their skills. That's not good for dentistry or surgeons or pilots or skydivers, right? I mean, that's not really effective. And it affects all of us due to pockets of incompetence that we don't recognize. I'm not even talking about professionally. Like, you might not be as good of a tennis player as you think you are, or you may not be as good of a singer as you think you are, or I may not be as good of a lover as I think I am. I'm just kidding, I'm amazing. I am. I know that was a bad example to use because I'm amazing. I have the Yelp reviews to prove it as well. And so if you look at this effect, you can actually graph it out. And there's a graph that occurs, and it's based on two things: how much confidence somebody has in what they're doing, and then their knowledge or their experience in that field. And so this curve starts down here in the bottom with low confidence and low knowledge about what you're doing. This is basically the first day of dental school where you show up and you don't even know what questions to ask. You're just unpacking your instruments, and they look like medieval torture devices, and you're learning mesial and distal and occlusal and words you've never heard before. It's amazing that as Americans who can't learn a second language, we actually learn dental words. So I guess that proves we could learn a second language, but we're just lazy when it comes to German, Spanish, French, or the other. Poor translators, I'm talking so fast. But so this is the first thing, is kind of this HUD, this cluelessness with the low knowledge. And then you quickly do your first few procedures or whatever you might be doing. It could even be skydiving. And all of a sudden you get up to, oh, I know everything. And usually it's because somebody has cherry-picked cases for you, or you're jumping with an instructor, or something's happening, and all of a sudden you feel like you know everything. But as you gain more experience in the field, whether it's dental CAD/CAM, whether it's surgically placing implants, whatever it might be, now you run into some bumps in the road and you start to slide down. And as your knowledge increases, you realize there's more to this than I thought. And that's a necessary realization. But it's really not until you get down to, I'm never going to understand this, when you have a couple failures in a row. And this is what spurs you on to learn more, whether it's to attend a conference like this, in person or online, or talk to your colleagues, or whatever you need to do to start to sharpen up your skills. But this is not a fun feeling right here. But the good news is, if you push through, you begin to go up this curve, and it starts to make sense to you. Things become a little more predictable. Your actual confidence increases as your knowledge increases, and then the longer you spend in the field, you start to get really good at something. This flattens off a bit, and then trust me, it's complicated. But I know what I'm doing. I've spent a lot of time studying. And sometimes I even say this to patients, but in a respectful way. It's not that I won't explain things to them. It's that there needs to be some trust for the experience and how you've gone through this curve. Another way to look at it, this same curve is like with our children as they grow up. And as your knowledge increases just in life in general about how life works, you start here at birth. And then I have two kids that are teenagers, and they're up here right now. And I call that Mount Stupid. So this is where they really haven't experienced much adversity or struggle or anything yet in their life. We've probably spoiled them. I mean, me, my wife, and I have probably spoiled them. It's probably our fault. I don't know if our parents did that to us. They did a little bit, but I don't think like we've done to them. But then my oldest daughter, she's down here now at what we call the Valley of Despair, because she got her first job, and then she got furloughed or laid off because of coronavirus. And then her and her boyfriend broke up during the lockdown. I don't know why. It's not like they were living together, but they broke up too. And for her, it doesn't seem like life's going to go on, because she didn't even know about the stock market crash in 2007 or black money or all the other things we saw. Till showed some of those things just in the last 10 years. And the earth always recovers, and people always recover as these things tend to happen. And obviously we will after coronavirus as well, or it becomes part of our lives. like the other coronavirus that's out there that causes 30% of the common colds. And then after that, as you begin to get more experience, there's this slope of enlightenment, and this is the really fun part, whether it's pushing through digital dentistry. This is where you see growth in not only in confidence, but in your abilities to do stuff that you don't see anywhere else. And then the longer you spend in the industry, you get to this plateau of sustainability, and it does start to flatten off, mainly because you start bumping up against what dentistry knows. So for example, when I graduated from dental school in 1988, molars, a maxillary molar had 3 canals in it. 20 years later, I was in endo course where I learned that maxillary molars have 4 canals in them. And it's hard for me to figure out how in just 20 short years, evolution gave human beings a 4th canal. It doesn't make sense. I don't know what the evolutionary advantage of that is. Or maybe it was always there, and that's why I saw some of what I did, Valley of Despair in endo, until Steve Buchanan started showing us what the 3-dimensional pulp chambers and lateral canals and all these things look like. So there's times where you bump up against how much knowledge there is in your field, but as long as it starts to flatten off, you'll still have a slow improvement, and your confidence and your happiness will go on. This is what Dunningkruger looks like in dentistry. So I practiced for 15 years inside of Glidewell Laboratories. I think it's still the largest dental laboratory in the world in Southern California. And this is one of the cases a dentist sent into us. So I decided to call him personally, because every once in a while I get obsessed with dentists. I know, like, my wife's obsessed with the British royal family. I could care less about them, but I'm obsessed with dentists who do stuff like this. I have to know what makes them tick. I want to know what drives them. And I called the dentist and I said, hey, this prep that you sent in, did you get a chance to take a look at the impression before you sent it in? Yeah. Were you able to see the margins? Yeah, I think I could see all the margins. And I'm like, okay. Well, it looks like there was actually more preparation done to the soft tissue than the hard tissue. That's usually not how we do preparations. And not only that, on the occlusal surface, I don't see a diamond burr mark anywhere. How is that reduced? Is this like the Rodin sculpture technique with a hammer and a chisel? And also, this is about 1 millimeter tall. We haven't invented the cement yet that'll hold that on. And you wonder, where is this disconnect? This was sent in by a licensed dentist in the United States, I think. I don't know, maybe one of his cleaning crew did it. He's just, covering for them. That would actually make me feel a little bit better. And Michael Shear yesterday was talking about all-on-X implants. But when he was talking about the X, where the X can be any number of implants, I'm not sure he's talking about this dentist, where X equals 1. Is that what he was thinking? I like to say something good about every case, so I will say this. If you're just going to place 1 implant in the mandible, that's pretty damn good, right? They nailed the midline. That looks good. And I'm not a physicist, but I'm pretty sure this is what we call a lever arm. And so even though you're very conservative and you just use 1 implant, you have to give very specific instructions to the patient, such as don't chew here or here. Here, 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 here. Right here's where you're going to choose 24 and 25 or 3, 1, 4, 1, and 1, 1, and 2, 1. That's it. So from now on, all the foods you eat in life won't be based on preferences, taste, or texture. Everything needs to be long and thin. Licorice, string cheese, tiny Slim Jim sausages, anything you just eat in that power zone, and you're actually going to be safe. But these 2 dentists fascinated me as well. A laboratory technician brought this to me and said, what is this? I said, it's bite registration. She said, well, it's all the dentist sent with the case. I said, well, call the dentist and see if they forgot to send the impression. So she came back and said, no, the dentist said that was the impression. I said, that's not an impression. She said, how can you tell? I said, there's no tray for one thing. Second of all, it's just bite registration that's been relined with light body material, and it only shows, the prep, the opposing tooth, and the distal surface of the tooth in front of it. That's a bite registration, but no, that's what here's his cousin, no tray bridge guy. What's this no tray movement in the United States that I've missed out on? What, is there some global or U.S. conspiracy theory? Well, there is a lot of U.S. conspiracy, but is there one that says Shine's marking up impression trays 15,000%? And the way to become independently wealthy in dentistry is not use impression trays? That was just a one-off case. This is the guy who I became obsessed with. This is a doctor in Florida. And he does a lot of work and sends it to the laboratory. So I had the technician bring me every case that this doctor sent in. They were all just like this. 95% of what he does is single unit crowns. And they all look just like this. And I became fascinated. I wanted to follow it down to the plaster department, because how do you deal with something like this? I wanted to see if they have a tiny little bowl and a tiny spatula where they mix a little bit of plaster and they pour it in with a tiny pin and tiny vertex articulator on the back so it's all ready to go. I just wanted to see how they were going to actually handle this. And this doctor, we used to call him by his surname in the office because he became a legend within the lab, as you no doubt. This would be the topic of conversation every morning. Show me what he brought in. But we stopped calling by his real name and just started calling him Tiny Impression Guy. Again, I don't know how to translate that into other languages, Tiny Impression Guy, but this became his name because this is all that he ever sent in. And the shocking thing about him was this was the first doctor I ever looked at that had a remake rate less than 1% in the laboratory. I was practicing inside the lab in a building with 850 technicians, and I was working with one named Cindy who was really good, and my remake rate practicing inside the lab was 6 to 7%. We'll call it 7%. Why? Well, we've identified 66 steps from the time you finish a prep till you get the crown back from the lab. Things go wrong. Things get distorted. Usually the patient's fault. I say that practicing within the lab. All the other dentists blame the lab, but we know it's a lot of time it's the dentist's fault. It doesn't matter whose fault it is, but you have to have a quality control filter. And so with a 7% remake rate, out of the 100 crowns Cindy would bring me, 93 would go to place just fine, and then 7 would need a reshade or an adjustment or something was distorted. And that's fine. You almost don't remember those when 93 of them go so smoothly. And frankly, without those 7, we'll never learn anything, right? All we're doing with those 93 is just reaffirming what we already know. It's not until we step out in that gray zone and then have to struggle and remake things that we actually learn something. That's why it's so valuable to share our failures with our colleagues. It's more fun to show all our really pretty stuff and success, but to really teach and to really get some understanding and help them get out of that valley of despair, we have to share our failures. He hardly has any failures, which is a little hard to believe considering this. In fact, to find his last remake, I had to go 3 years back into his record. And he's in Florida. We have another dentist with the same name in Seattle, Washington, on the other side of the country. They both worked on a patient named Carol. There's no last names because of HIPAA. We just have first names on all the lab slips. And they both did a crown on a lower left first molar. The doctor in Seattle called and said, "This is weird. I have a case here with my name on it, Carol's name, and I've got a crown for a lower left first molar, but there's a wisdom tooth on this model and she doesn't have a wisdom tooth." He didn't notice it was the wrong account number on there. So he sent it back to us. We said, "We'll figure it out. It's a big lab." And we realized we had switched the cases by mistake. So we called Tiny Impression Guy's office and we said, "Hey, we sent you guys the wrong crown, but we have the right one here. Can you send that crown back to us?" And the dental assistant got on the phone and said, "I would, but I'm pretty sure we cemented that yesterday." And we were like, no, tiny dental assistant, that didn't happen because that crown was for a different human being. That didn't happen. And she called us back a couple hours later and said, "We did cement it yesterday, but doctor wanted you to know that it took him 30 minutes to get it down." I was like, oh. And that's why we stopped calling him Tiny Impression Guy that day, and we started calling him Dr. Reverse CEREC. And the reason so you look at CEREC, you look like a chairside, any chairside system. You prep the tooth, you scan it, you mill the crown, chromosomes with the truth. Okay, impressive. We all love it. It's what exocad's all about. Dr. Reverse CEREC, you send him any crown. Now, it's got to be a lower left first molar. You can't send him a central incisor. He's not a magician. It's got to be a lower left first molar. He picks up the crown. He does an optical scan. Unfortunately, he's not running exocad level software in his head. So he makes some estimations, and he mills the tooth. Mill, try, mill, try. 35 minutes later, it's down. Didn't have to invest a penny in any high-tech digital equipment either. He's scary with that low remake rate. In fact, I looked through the lab. There was almost 4,300 dentists with a 50% or higher remake rate in 2019. These aren't fun as a lab owner, right? Where every other crown's a remake. This isn't fun as a dentist either, by the way, even though it's the dentist's fault. I don't know why these dentists continue on and don't go into real estate or something else. This is a really sad way to practice when your assistant says, "Do you think the next crown will fit?" And you go, "Hold on," you flip a coin. No, I don't. Because it's a 50-50 chance if the restoration is going to fit. But you know what I love about these doctors? They're honest. They still tell their patient, even though they've been beaten down by dentistry. They try on the third crown of the day, and when it doesn't fit, they look at the patient and say, "You know what? I wouldn't put this in my mom's mouth or sister's mouth, so I don't want to put in yours. Let's take a new impression. We'll get a better one back next time." So I respect them. These dentists scare me. The almost 5,300 dentists with literally a 0% remake rate in 2019. No quality control filter. God has like a 2% remake rate. It's just, it doesn't happen that you're going to have a 0% remake rate. And you say, "Well, Mike, maybe it's a statistical aberration. Maybe all these dentists just sent one crown to the lab because they got a coupon and they didn't really like it, but they cemented it and never tried it again." Well, I counted. There was 660,000 crowns between them. It's crazy what's happening in the estimation. So here's how I sum it up when I talk to dentists. In reality, a crown and bridge impression is merely a reflection of the dentist's integrity, nothing more and nothing less. Now, I'll admit, practicing within a lab for 15 years, I've been influenced by technicians because they took out all their aggression on me. They wouldn't yell at a paying customer, but they'd come down and yell at me, even about my own preps. Technicians made me a much better, technicians teaching me allowed me to get above average results with a below average set of hands. But I really feel that this is true about a dentist, not one crown and bridge impression, but any lab owner in here, if they broke a tooth and I say, who would you go see? They'll tell me 3 dentists. Right, 3 of their clients. I go, why, are they the cheapest? I go, I have no idea what they charge, but I see all their preps and impressions. Lab techs are the only ones who know how good dentists really are or know how good their integrity is, because it's not about skill. This is not about skill. There's no skill here because I have below average hands. It's just a 2-core technique. This is just slowing down, doing things right. It's not skill. Yes, but it doesn't matter about your hands. It kind of does, but there's hands, there's eyes, magnification, whether it's with loops, it should be with loops and with blowing it up with a digital impression. There's brain, obviously, it connects the two. You have to be able to go out and study and learn, but there's heart, and that's the one that we rarely kind of talk about. And what I mean by heart is you have to care enough to get good results on the patient. You're not working at a car wash where if you leave a little spot of dirt, it's okay, they'll come back next week. We're altering the human body. And I get they have 28 teeth. It's not like heart surgery where a patient only has 2 or 1 or whatever. I didn't do well in anatomy class, but it's 28 teeth, but still it's a piece of their body. We've got to do a little bit better. And this isn't skill. This is just a technique that anybody can learn. And in California, dental assistants can legally do this. So when you talk to dentists, you can pretty much fit any dentist somewhere into these 4 quadrants. This is prep speed, how quickly you prep, and this is prep quality on this axis. And so when you get out of dental school, you are in the apprentice stage. In 1988, we had to do 27 crowns to graduate from the University of the Pacific. I talk to recent graduates all the time in the US who do between 3 and 6 crowns before they graduate. And I did less than my dad did, who was a dentist a generation before me. So we see that the clinical training is shrinking because other stuff is coming into a limited curriculum. And God, now they're doing dental school at distance and not going into schools just yet. So we'll see what happens with this class. But that's okay. Your preps are supposed to be so-so, and your speed should not be good when you come out of school. That is expected, except for the rare superstars. If we move up here, this is where tiny impression guy is. We call them cutters, at least in American labs. That's what we call them because they do a ton of preps. Tiny impression guy sends us 3 or 4 crown impressions, those tiny little things, every day. By the way, he's about the best lab client you could ever have. Now, this might weigh on your conscience, what he's doing, but he never has remakes. He never even calls the lab. You don't even know he exists, except he sends these in and you send the crowns back, and he's got a credit card on automatic payment and it always goes through because he wants to make sure everything goes smoothly because he doesn't want to have a conversation about the preps. So he's kind of the dream lab client, these cutters, because they tend to be really fast, but the quality, you would never send, a family member there to have dentistry done. In this quadrant, we have the artists, where the prep quality is great, but they've never really increased their speed much since they got out of school, maybe 10 or 15%. And much like yesterday, this isn't about let's see how fast we can go. For a while in the US, back when I started practicing, there was this 90-second crown prep somebody was pushing. That's ridiculous. This isn't a race, but this is something that physical that we're doing. And you should get faster, whether it's cycling or whether it's running over time. And that includes crown and bridge. You should get more efficient. There should be less wasted movement. Your assistant should be able to anticipate what you're going to need next. Patients appreciate it when they're not there for twice as long. The tooth appreciates it when it's not got all its enamel off, getting dehydrated. There's a reason clinical reasons we want to get efficient too. And so it's not about trying to get a lot of speed. It's about not kind of diddling and being able to become efficient, because as we move up, that's when we go into master territory. And these are the dentists who can be very efficient and can place a whole arch of implants like we saw yesterday while taking out and extracting teeth. That was very efficient dentistry. It's like a $60,000 case when you look at everything that's being done. It was thankfully being donated. But that's what efficiency looks like. And there was 5 people in the room. I turned to Mike, I go, do you have 5 people with you during your surgery? He goes, God, I wish. And it's like, but he knows an oral surgeon who has 5 people there. One assistant, he said, is just there to hold the patient's mandible down while they're working. But that's where you get to efficiency, and you can do these cases quicker than you did 10 years ago. So how do we get to being a master? I ask a question in every dental lecture, at the beginning of every lecture, and I say, put your hand up if you'd like to become a better dentist, a better clinical dentist. And 90% of the hands go up in the room. 10% of the hands don't go up because they're just out of principle. They will not participate in any casual surveys that you throw out there. But 90% of the dentists put their hand up. And then over the next 5 hours, you show them what it takes to start to migrate towards master territory. And it's stuff like money, right? I mean, it's investing in some stuff. It's investing in taking courses and stuff like that. A lot of the time, it's slowing down and doing things. Sometimes it's delegating things to an assistant who won't rush through it as much and might take, more pride in certain aspects or not get as frustrated, whether it's packing cord or whatever it might be with her as part of it too. But when you tell them for 5 hours, you can see mentally the hands kind of start to go down when you say, who wants to be a better dentist? And it's not unlike if I said, who would like to lose 10 to 15 pounds? 90% of the hands might go up, and I go, great, we're meeting outside the Welcome Hotel tomorrow, 5 a.m. Just gonna do a 5K. It's just gonna be mainly walking with a couple of jogs. And this is gonna be step 1, and we're gonna meet there every day for the next 90 days, because that's how you form a habit. And you can just see everybody's hands kind of going down like, 5? I'm usually kind of like sleeping then, or I don't know if I can be there in front of the Welcome Hotel. So people want to go there, but when they see what has to be done. But how do you get there? What's the quickest way to get to mastership? It's digital dentistry. It was for me. It was the opening of my eyes. It was working with technicians. For 15 years, my only patients were dental technicians. These are the only patients who ever got mad when I didn't reduce enough. That's how I learned to reduce more. They'd come back with their models and get mad and say, re-anesthetize me and prep more. I began to realize, what happens when you don't prep enough and how angry. I mean, it's the number 1 complaint of every lab owner I've ever talked to. And dentists are just doing it by the seat of their pants. Like in the United States, the average dentist just preps till his hand gets tired and then sets the handpiece down. And then has takes the cheek, pulls it out, has the patient close, and then magically thinks they can look back and see the lingual cusp on a second molar. Where it's dark in the back there. It's 100% humidity. It's practically raining in the back of the mouth. And a dentist thinks they can close one eye and look back there and see how much they've reduced. It's magical thinking. It's illusory superiority. It's Dunningkruger personified. It's crazy. So I had to come up with a prep technique on my own that's all based on depth cuts. And my margins were always awful. So I found a way to take a round burr as the first step of the procedure. I prep the margin before I prep anything else with a round diamond. And then I do depth cuts and connect it all. Because I had to get technicians to stop screaming at me. It's called the reverse preparation technique. If you want to look it up, it's one of the videos that's online. But I had to do it for my own survival. And then I was like, maybe this will help other people. And a lot of people who tried say, well, that's the easiest way to make a margin that I've ever done. So I had to do it because of my below average hands. Digital dentistry is how you get there. And you guys know, obviously exocad knows this. Magnify your preparation so you can inspect the margins. Dentists go, I feel like I can see them good enough with my loupes, if they're using loupes. Hopefully they're using loupes. I go, well, your lab's blowing it up 20%. You know what else your lab's doing? They're clicking on the opposing tooth and then the prep, instantly knowing that you only prep 0.8 millimeters for an Emax crown that needs a minimum of 1 millimeter thickness. The labs are checking up on our homework. They know you can't lie to the lab anymore. Labs used to call a dentist and say, I don't think you reduced enough. And the dentist goes, I'm pretty sure I did. The lab goes, I'm not sure you did. And the lab goes, remember, I'm writing the check to you. And the lab would have to go, yeah, you're right, doctor. Now, I just held it at a different angle. Yeah, you're absolutely right. Not anymore. They'll send you a screenshot showing the 0.8 millimeters. And so dentists come in and they memorize, it's got to be 1 millimeter thick. Are you using depth cutters? No. Then stop. Don't even write it down. Because you're giving yourself a false sense of security that you've memorized these thicknesses, but you're practically doing nothing to be able to give your lab techs. We have such a bad habit as dentists of prepping teeth, taking an impression, putting on temp, sending the patient away, sending the impression to the lab and saying, do your best. Do your best now that we've tied both hands behind your back, or at least one of them. Now we're throwing down the quality gauntlet. We're going to draw the line in the sand. Now do your best. What happened during the prep? That's one of the things I love about this, being able to check how much reduction you've done, being able to look at a virtual model. Our brains like to see positive images like a model or a virtual model. They're not used to seeing an abyss like in polyvinyl siloxane and being able to read what that is unless you specifically know what to look like. It allows technicians, here's my technician, Cindy, helping a friend of mine. Wow, this is back in the day when the blue cam was still being used. I can tell he's got powder on his camera. That's what she's probably telling him right now. But I learned a big lesson when I started having Cindy come in the room. She had to approve all my anterior preps, before I would take the impression. And guess what? If you want to do one single thing as dentists to get much better anterior, aesthetics from your lab without paying a penny more, this is what you'll do. This is just desktop sharing software, where a dentist who was using a Sirona unit with the blue cam was letting Cindy look at a full arch of, I don't remember if that was solid zirconia or lithium disilicate, but the technician gets to approve all anterior preparations. In fact, if you were a lab and you said, I don't want to work with dentists who don't let my technician or let me approve the preps, I'd say good for you. Because I'm telling you what, as a dentist, it makes all the difference in the world. Unless you've made 100 Emax anterior crowns, as a dentist, you don't get to have the final vote on the preps. You just don't. I mean, you can, but you should clear it with the technician who actually knows how much clearance they need to build it up. Why wouldn't you? This is an expert. Laboratories are specialists. I don't see any difference between laboratories, endodontists, oral surgeons. Laboratories are specialists. They're the indirect restoration experts. Why wouldn't you let them in to see your preps? You really want to get something back where you have bucky restorations or there's a thin spot on the lingual because you didn't reduce enough? It's silly. It allows you to correct the prep while the patient's still there and numb. The technician can improve the impression too, so you never have to re-impress. The dentist can fabricate simple restorations in office. All I'm talking about is single unit posterior solid zirconia restorations labs. I'm not saying they should start. They don't want to do anything else. We can't get dentists in the US to even adopt doing those single units in office. I'll talk about that in a second. And at Glidewell, we started giving a discount for digital impressions. So because we got to do way less plaster work when we got a digital impression, it saved us $18 worth of man hour and supplies. So we gave the doctors $20 off because in America, they need a real honest to goodness kind of ROI sometimes to invest in equipment like that. They won't do it just because it's the right thing. The percent of dentists sending digital impressions was 6% back in 2015. It's been 5 years. How's it doing? Not that good. It's at 18%. And in the US, 91% of the impressions that came in last year, according to LMT, still conventional impressions. Because if you just compare a digital scanner to the impression gun with PVE, this one looks pretty good. And frankly, for the average dentist, it works better because you can do some hacky things with polyvinyl. You can push blood out of the way. You can push tissue out of the way. You have to treat tissue better to make digital impressions work. In fact, a line should not sell a scanner to a dentist until they can walk up at a show and show them a polyvinyl siloxane impression that would meet with the laboratory technician's approval. Once you show us you can do that, now you're really going to enjoy all the benefits. If you can't take that impression in polyvinyl, your remakes are going to go up with digital, and then you're going to talk crap about digital to all your friends and want to return the unit. Right now, it's not for everybody. Until we get a technology that can see through tissue, see through blood, see through saliva, and make up for those shortcomings in tissue management, right now it's still something that makes good dentists much better dentists. But those average ones and below average ones, they're going to get super frustrated, and so will the lab. As dentists, we need to be better for ourselves so we can sleep at night. The way we just prep teeth without using depth cuts and by the seat of our pants, if US dentists were pilots, planes would be falling out of the sky because no one would ever check to see if the flaps were set. Nobody would ever check rotational speed. It's just, I can't tell you what you see, and there's just no depth cuts being used to know you're in the right place. So they work 90% of the time. They don't work if you're taking off an old crown, but I've got ways around that too. We need to do it for our labs. They deserve better. We wouldn't send stuff like this to our other specialists. We can't do it to our labs. Our patients, for the most, are the most deserving of us doing better, trying better, getting better clinical results, whatever that takes. We need exocad to continue to make digital easier. And so it's tempting sometimes for an R&D department to add more and more features. And let's get our power users able to do full arch dentistry and full mouth dentistry. I'm more concerned about the average dentist out there who's still not considering chairside CAD/CAM because they need it to be a lot easier. I mean, it almost needs to be press the green button that says crown on the screen, and then a robot arm goes and picks up the block and then mills it. And we have one of these at Glidewell, a prototype that's actually doing it, and then it needs to go on a little like a pizza oven thing where it gets glazed, stain, and then it goes through the oven and then glazed. And I'm not saying this is tomorrow, but we need to continue to make it easier so we get more dentists involved, so more patients can benefit from it. And I know the power users, and it's great to see them do stuff, but I'd like to see less new features and more simplistic features, almost less tools. Get our proposals correct 99.9. And I'm not talking about exocad. I worked for Strona for 3 years. That's really what I'm talking about, is what the arguments that I used to have with the R&D department. We need labs to be willing to help dentists learn digital, including encouraging them to make simple single unit posterior crowns in their office. Labs, you're specialists. Endodontists are happy to let us do the easy root canals, and then they do the hard special ones because they're specialists and they charge way more than we do as general dentists for the general ones. I want you to see yourself that way. Be the one that helps the dentist learn how to do these simple single unit posterior crowns in their office. And they will love you and send you tons of stuff. I know this because when I surgically placed my first implant, my oral surgeon was there standing behind me with his hand on my shoulder. In retrospect, that wasn't necessary, but his hand literally was on my shoulder. I had a surgical guide, and I was brimming with confidence, Mount Stupid, but he was standing there. I knew nothing would go wrong, and if it did go wrong, he'd show me how to do it. I'm like married to him now. I wouldn't consider sending to anybody else. He taught me how to do this. I mean, otherwise it would have been really stressful to do that. Be that for your dentist. Be the one who gets them into digital dentistry. Be the impetus for them to start doing better dentistry. Let them do the simple crowns there. They'll send you the multiple units, the bridges, the anterior units, the implant cases, and charge more for that when you charge them, and encourage them to do those in their office. Don't be afraid of letting dentists do it. That's how it should be. And the last thing we need to do, well, two things. Educators, we need to continue to plead with dentists to do the right thing for their patients. And we need to find creative ways to do it so they're going to want to do it. Because again, when you see crown and bridge impressions and you realize it's a reflection of integrity, that reason's not always going to work. We need to find creative reasons for them to do it. And lastly, as a team, us and dental laboratories, we need to deliver restorations faster. Obviously, exocad wants it same day, and I totally agree. That is the ideal. But in the meantime, in the US, when we don't have that many dentists playing with it, this 2-week temporary crown we're living with, it's got to go away. It's got to be abolished. It's the reason remakes are so high. A well-meaning dental assistant polishes a temporary super smooth for all the right reasons so it won't bother the patient's cheek or the patient's tongue. And accidentally, because Bisacril is kind of soft, she takes it 350 microns out of occlusion. And she asks the patient, how does it feel? And they go, I can't even feel it. Okay, well, this is not touching. It's 350 microns out of occlusion. In 2 weeks, that tooth will absolutely super erupt. The crown will come back, try it in, it'll be high. The dentist will destroy all the anatomy that you put into the crown, and then they'll complain that it took too long to seat it, and it looks awful because they had to destroy it because the lab made it high. It's the temporary crown. It's evil. The 2-week temporary crown is evil. For the last 11 years, I've been seating everything 3 days after the prep. We all know that if a crown stays in 8 weeks, 12 weeks, 20 weeks, the chances of it fitting exponentially decrease. I'm here to tell you the opposite's true. You know this from same-day dentistry. But in the meantime, instead of waiting till we get to the day where everybody goes to same-day dentistry, let's shorten that up. Let's have our dentists start seating crowns after 3 days. It's transformational in the office. Crowns are dropping in. You're rarely adjusting occlusal surfaces. You're not putting microfractures into the crown that'll connect over time and cause premature restoration failure. Even if your assistant still over-polishes the temporary, the effects of it after 3 days are far less injurious than if it's in there for 2 weeks. But this requires your dentist to have a digital scanner. I'm not saying do this for everybody. This is a dentist who can prep a tooth at 10 a.m. on a Monday, scan it, have it to you 2 minutes later. You mill lithium disilicate or solid zirconia, whatever, sinter it overnight, get it back to them on the 3rd day. It's got to be for dentists who have digital units, not somebody sending an impression. And you can charge a premium or do it experimentally with some of your best accounts. I'm telling you, the way stuff drops in and you don't have to adjust it, it's the right thing to do for us, for our patients certainly, and for the tooth itself. We've got this piece of plastic with bad margins on there for 2 weeks with this cement that's designed to fail. So that 2 weeks later, we can take some forceps and wiggle it off and none of it will stick to the tooth. It leaks like a sieve. And when you put 2 coats of Gluma on it before the temporary goes on, 3 days later, I don't even do anesthetize to do 90% of the crown seats, plus the 2 coats of Gluma. We put another 2 coats on before the permanent crown goes on, kills 99.9% of all the bacteria that are on there anyway, to stop with post-operative sensitivity and possible endo down the road. So thank you for letting me spend a little time with you. Thanks to exocad for putting on this meeting. And I hope that I hope you get a chance to interact with your dentist. And as dentists, we need to realistically kind of look at where we are, if we believe we're better than average or not. And hopefully some of the stuff that I've done and talked about and put online can help some dentists get some better clinical results, because there's only 10% of our class that has those great hands in dental school. The other 90% of us have to do something else. So really, this is a message of hope. Thanks, you guys.